But remember that the equation for mid ventilation on high frequency is frequency times tidal volume square. So the influence of the volume, the tidal volume on the mid ventilation is way, way higher and stronger than frequency. So don't be afraid to decrease your frequency. You may have to increase your PIP a little bit if you're on the jet to compensate for that slight drop in mid ventilation, but it shouldn't really give you a big trouble with the CO2 by decreasing the frequency.
Thank you very much. I think the second moderator will moderate the second lesson, the second lecture. Thank you very much, Ruben.
Thank you, Jabara.
Hello, my name is Iman Badran. I'm professor of pediatrics. I'm trying to open the camera. I don't know. Yes. Okay. I'm professor of pediatrics. I'm really enjoyed your previous presentation. And now let's go with your next presentation on algorithm and approach to non-invasive ventilation.
Very good. Thank you.
Yeah.
Can you see my slide now?
Yes.
Okay. So I have nothing to disclose. The objective of today's presentation will be first to identify the basic principles of non-invasive ventilation, to describe the different type of non-invasive devices, and to describe the advantages and limitations of non-invasive ventilation in preterm infants. So what's NIV? For some reason, my slide is moving by itself. Anyway, so hopefully it won't continue doing that. So what's NIV? Well, you know that mechanical ventilation has been associated with significant lung disease. Just the fact of having an endotracheal tube present in the airway is associated with increased risk of infection and also increased risk for airway trauma. That added to the volume trauma, the atelectal trauma, the volume trauma will tell us that maybe it will be much, much better and lung protective to try to ventilate the baby without endotracheal tube. And that's what we're trying to do with non-invasive ventilation. It's much more physiologic to try to control the CO2 and oxygenation, allowing the baby to control his own respiratory rate and tidal volume than what we can do with a machine. So that's why over the last 10, 15 years, more and more we are trying to switch our mode of ventilation to a non-invasive mode and see if we can avoid putting the endotracheal tube in these babies. Now, the core element of non-invasive ventilation continues to be the CPAP. So the CPAP remains the core element. And what we are doing with non-invasive ventilation is to try to add some breath on top of that CPAP pressure. So it's a mode of respiratory support that increases alveolar ventilation without the need of endotracheal access, either intubation or tracheostomy. Again, nasal CPAP with superimposed either non-synchronized, called NIPPV, or synchronized SNIPPV ventilator. It's what we mostly call non-invasive ventilation. The main goal of non-invasive ventilation is to prevent intubation and mechanical ventilation. Again, it's not to aim for normal gases or normal oxygenation. It's just to prevent intubation and mechanical ventilation at all costs. So we know how CPAP works. We have studied CPAP for a long, long time. We have a very good idea how CPAP helps us with oxygenation and ventilation, although we don't know exactly how NIV works. There are some studies that have showed some differences between non-invasive ventilation and just CPAP. One of those studies has shown that you can get a better minute ventilation tidal volume by using a non-invasive ventilation over CPAP. You may also have a better synchrony, thorac-abdominal synchrony when you use NIV. We have also decreased work of breathing compared to CPAP. you may have a better increased oxygenation, and also you may have better control of apneas through the stimulation of airway reflexes. And in the case of obstructive apneas, non-invasive ventilation may actually be more effective than just regular CPAP to try to keep that airway open and prevent the closure of the airway during mixed apneas. Now, I'm going to classify or show you the different mode of ventilation or non-invasive ventilation that are available right now. In terms of CPAP, as you know, there are three types of CPAP: the bubble CPAP, the continuous flow, which is the CPAP that the ventilator delivers, and the variable flow CPAP. Now, I'm not going to tell you that any of these mode of CPAPs is superior to the other one, because none of the studies has shown significant differences between the three modes of CPAP. The bubble CPAP is the simplest way, the cheapest ways, and is as effective as the other two. If there are minimal differences between the three modes of CPAP, is not related to the CPAP itself, but is the fact that maybe your nursing personnel is maybe more familiar with one than the other, and that's why you may get better results with one type of CPAP than the other. So whatever CPAP you're using, get familiar with that and keep using that, because again, there is no significant difference in the three modes. Then we have the NIPPV, or it's called intermittent positive pressure ventilation through the nose. That can be classified either into synchronized or SNIPPV, or non-synchronized or NIPPV. The synchronization of the NIPPV can be done by an abdominal capsule or by flow and eval of the nose. Unfortunately, the abdominal capsule never really worked very well. It was never very sensitive, and it's not available in the market anymore. Now, the flow synchronization is relatively new, and it's very promising, although there are not many studies showing how good that synchronization is with the flow. So we need more studies to know exactly how to use this flow to better synchronize our non-invasive ventilation. Now, what we know about how effective is this non-invasive ventilation in terms of studies, we know that NIPPV reduces the rate of respiratory failure and intubation among preterm infants with RDS when compared to nasal CPAP. And that was a meta-analysis done the Cochrane database in 2016. Another Cochrane study done in 2017 showed that NIPPV reduces the need for reintubation when compared to nasal CPAP. So decreased rate of respiratory failure and decreased need for reintubation. Now, what we know by a very large randomized controlled trial done by Keith Palani, published in New England Journal of 2013, is that NIPPV does not improve the outcome of death or BPD when compared to nasal CPAP. Now, I have to make a clarification about this study. This study did not really compare NIPPV with CPAP, and most of the centers during this randomized trial used bi-level CPAP or inflant flow CPAP. So it was not a true NIPPV mode that was used in most centers. So I think we need to really do a proper study using either NIPPV or SNIPPV compared to CPAP to see if we can get better mortality rates and less BPD. Now, in terms of synchronized versus non-synchronized NIV, now, when you think about it, it makes a lot of sense that the synchronization will be better. Why? Because when you're not synchronizing, the machine is gonna deliver that breath regardless of what the baby is doing. So the machine may be delivering that breath when the baby is expiring, or maybe delivering the breath when the airway is closed. And that will create a lot of asynchrony at the chest, and that may not be good for ventilation. So ideally, you want to deliver that ventilator breath when the baby is inspiring and when the airway is open. So again, it will, in theory, give you better ventilation, gas exchange, and reduce breathing efforts if you can synchronize those breaths. it will provide the infant the ability to vary his own or her respiratory rate without the interference with the ventilator. So the ventilator will adjust with the baby's own spontaneous breathing. And also by coordinating the baby's own spontaneous breath with the ventilator, that will help to decrease the airway resistance by maintaining the coordination of the airway, dilator muscles, and the diaphragm. And that should also help to improve ventilation. Now, having said all this, there is no real studies comparing synchronization versus non-synchronization. So all these things that I put in here are in theory, and we need to prove that this is actually true in real life. So there's no trials that have compared synchronized with non-synchronized NIV on important outcomes. There is no trial that have examined the accuracy of synchronization devices in NIV. And finally, there is no trial that have properly evaluated the advantages of synchronization during nasal ventilation. Doesn't mean that it's not better, it means that we don't know, that we need to do these studies. Now, in terms of the type of nasal interfaces that we use for non-invasive ventilation, they're basically the same type that we use for nasal CPAP. Short binasal prongs are by far the better ones, especially when you compare to a single nasopharyngeal tube, because of the decreased work of breathing in the binasal prongs. So binasal prongs are the interface that are recommended for any type of non-invasive ventilation. We have the Hudson cannula that is very bulky, very stiff. It's very hard to keep in place. The nurses hate these prongs. And we used to have these prongs in the unit. We don't have it anymore. They are good because they're big. They have decreased resistance, but they're very difficult to keep in place and causes a lot of nasal damage. The other ones are the old Argyle cannula. I don't think anybody's using these prongs anymore. They're very soft, but they're very small, and they have a significant increase in airway resistance. Then we have the flow generator that the most two common companies that produce this is the Infant Flow and the Arabella. The beauty about this nasal interface is that it uses the fluidic changes that allow for decreased work of breathing during expiration on expiration by flipping the flow from inspiration to the expiratory limb using the fluidic change. That in theory, again, decrease the work of breathing during non-invasive ventilation. The RAM cannula is something that was first introduced in California. It's very soft, very easy to use. In theory, the RAM cannula, because it's very small, will give you an increased work of breathing and increased airway resistance. However, people that are familiar with RAM cannula, they swear that it works very well. It can be used by NIPPV, can be used with a high frequency nasal ventilation, can also be used for high flow nasal cannula. The RAM cannula company has also come up with this fancy mask that also allow us to switch from nasal prong to mask to diminish the nasal damage that sometimes chronic use of these prongs can cause. And they're very soft, and actually you can get a much better seal sometimes using the mask compared to the nasal prongs. Then we have this heated, humidified, high flow nasal cannula. This has been a hot topic over the last 20 years or so. There are many centers that love this high flow nasal cannula because they're extremely easy to use. They give you a much better access to the baby's face. The parents love this this type of CPAP because they can see the baby's face better. You can improve feeding techniques and so on. And for the nursing, it's much easier to take care of than a regular CPAP interface. Now, the problem with the heated, humidified, high flow nasal cannula is that you have no idea how much pressure you are delivering. So that's why most of the studies have shown that compared to CPAP, this heated, humidified, high flow nasal cannula is inferior to a nasal CPAP. The possible mechanisms of action of high flow nasal cannula is that provide a distending pressure like CPAP, provides a dead space washout, what allows you to bring the CO2 down and decrease the inspiratory resistance. Now, the indications for heated, humidified, high flow could be used as a primary support for RDS, to treat apnea prematurity, to prevent extubation failure, and to wean from nasal CPAP. Now, the main concern with this, and I would not recommend using high flow nasal cannula as a primary mode of ventilation, is that you have unpredictable distending pressure. So we only use this high flow nasal cannula in bigger babies over 34 weeks that need very, very small amount of CPAP, 4 to 5. And every time we try to stop the distending pressure, the babies start requiring more oxygen, start increasing the work of breathing, and become more tachypnic. So we transition them to the high flow nasal cannula to facilitate feeding and better interaction with the parents, knowing that the babies do not need high peak pressures. So recommendation for the high flow nasal cannula is only use heated, humidified, high flow nasal cannula with flows over 2 liters per minute. Prongs should not be completely occluding the nerves. And also when you're gonna set the flow, consider the baby's weight. Usually we use 2 liters per minute per kilo. So a 2 kilo baby should have a flow of about 4. And because of the uncertainty about efficacy, safety, and lack of long-term outcome, is widespread use cannot be recommended in pediatrics. Now, what else do we have for non-invasive ventilation? The next one is nasal high-frequency ventilation. Now, we know that high-frequency ventilation is lung protective when you use it with a tracheal tube. So we thought, well, what about if you try to use this high-frequency ventilation without an endotracheal tube? Maybe we can get the same effect of removing CO2 and oxygenating without causing lung damage. So study has shown that this nasal high-frequency ventilation may have similar effects than NIPPV in reducing the need for reintubation when compared to CPAP, may decrease CO2 levels by improving alveolar ventilation when compared to nasal CPAP, may also decrease the rate of significant apneas when compared to nasal CPAP. And unfortunately, there have been no differences with CPAP in improving oxygenation, even when higher mineral pressure are used in high frequency compared to CPAP. So if you have a baby that is on is not intubated anymore and have problem with apneas or problem with CO2 and not significant issue with oxygenation, you may try nasal high frequency ventilation. There's a new mode, a fancy mode called NAVA, or narrow adjusted ventilatory assist, that has been in the market for some time now. There's still a lot of research being done with NAVA. It's a very expensive proposition. It requires a lot of training to use it properly. Basically what it does is allows a full synchronization between inspiration, expiration, and also the amount of support the baby needs to from the machine. So basically the way this is done is by having a esophageal catheter that is placed in the lower third of the esophagus that will measure the initiation of the diaphragmatic contractility. So the NAVA will initiate the support when the baby is initiating the contraction of the diaphragm, and will stop the support when the contraction of the diaphragm stops. But also this device, this electrode, will actually measure the change in intrathoracic pressure, and will use that to know how much pressure needs to deliver to achieve a pressure that you set. So if the baby's own respiration is very weak, the machine will deliver more support. If the baby's breath is very strong, the machine will deliver less support. So the way it works is that you have the initial spontaneous breathing, your breath done by the baby through the central nervous system going to the phrenic nerve. That will cause a diaphragmatic contraction. that will trigger the electrode in the esophageal catheter and will send information to the ventilatory unit saying you need to start kicking in now. That diaphragmatic contraction will produce chest and wall and lung expansion, and that will change your airway pressure, your flow, and your volume. And that information will also be sent to the ventilatory unit for the ventilatory unit to know how much pressure needs to deliver in that particular breath. So very fancy, but again, we don't have a lot of follow-up with NAVA. There are not many studies showing if they're significantly better or worse than NIPPV or SNIPPV, or even compared with the CPAP. It makes sense, although it's very complex, it's expensive, and requires a lot of training by physicians and nurses to use it properly. Now, so in summary, what are the problems with non-invasive ventilation? We have no long-term follow-up with this baby, so we don't exactly know. We have lab or commercially available good synchronization ventilator for NIV, although over the last 5 years, I would say there are more ventilators and now that have come with flow synchronization. As I always said, the success of non-invasive ventilation often depends more on the skills of the user than on the device-patient interface. NIV requires more careful non-invasive monitoring than does the ventilator implant. So get familiar, if you're in the unit, get familiar with one type of non-invasive ventilation. Try to get the most familiar with that device. Try to maximize that device before you move on and try a different one. And again, just because the baby is extubated and is moved from invasive to non-invasive ventilation, doesn't mean that the baby needs less nursing care. If anything, it's usually more difficult to care for a baby that is not intubated than a baby that is intubated. So you need to talk to your manager. Please tell them not to decrease the nurse-patient ratio when the baby is extubated to non-invasive ventilation. So here I'm going to show you, make a summary of the benefits and risk of all these different forms of non-invasive ventilation. So with CPAP, we know that CPAP improves VQ mismatch and oxygenation. We know that CPAP maintains FRC and decreases atelectasis. They also decrease work of breathing. The risk is that you have significant nasal traumas, especially if you use very bulky nasal prongs, a risk for air leaks, and risk for gastric distension. The high flow humidified nasal cannula its benefits are parenteral acceptance, easy of nursing care, similar effect to nasal CPAP, decreased gastric distension, but the problem is you get unmonitored distending pressure, and that could be risky because you may be giving too much or too little. You have no control on how much pressure you are giving. NIPPV, and also, again, the pressure could be too high or too low. For NIPPV, we know that improved gas exchange and oxygenation, maintains FRC, decrease work of breathing, and decrease for need for invasive ventilation. The risk of NIPPV is that causes nasal trauma, similar to CPAP. It's a risk for air leaks, and it causes gastric distension. So you need to be sure that you decompress the stomach very well when you use NIPPV. Nasal high-frequency ventilation, it's very similar. It decreases apneas and DSATs, improves ventilation, but there is limited data regarding the efficacy of nasal high-frequency ventilation. And again, there is also limited data for safety. With NAVA, we know that, let me move the things here, improve patient ventilator synchrony, improve patient comfort, and also decrease PIPs because you are delivering that pressure when the baby is impaired. So it's fully synchronized. The problem with NAVA is, again, there is limited data regarding efficacy and also limitation for extremely low birth weight infant when they have an immature respiratory control, and try to synchronize with that immature respiratory control may not be the best thing for the baby. So here we have an algorithm that we are using right now in our units that help us to decide when to switch to NIV or not. So if you have a baby that has mild Lyme disease with an intact respiratory drive, we usually extubate those babies to nasal CPAP using a PEEP that usually is about 1 centimeter water higher than the PEEP that baby was requiring when he was intubated. If the baby had moderate to severe lung disease or an unstable respiratory drive or has failed previous extubation to nasal CPAP, then we either switch the baby to either NIPPV, now we have synchronized NIPPV, or nasal high frequency ventilation. The reason I give you both is because we have two level 3 units here in Winnipeg, and one center started using nasal high frequency before NIPPV, and they feel much more comfortable using that first. The other hospital, on the contrary, you started using NIPPV before high frequency nasal ventilation, and they're more comfortable with NIPPV. So depending on which hospital you are, you may try one before the other or vice versa. Regardless, if you're gonna go to NIPPV, we use a PEEP that is usually 1 centimeter water higher than the PEEP that the baby was requiring when he was intubated. We use a delta P of about 7 to 10. So this is 7 to 10 millimeter of mercury higher than the PEEP. The inspiratory time should be a bit long, should be at least 0.5. And the rate, although here I said 15 to 20, there's nothing wrong with trying to increase the rate, especially if you're having problem with CO2 or significant apneas, going up on the rate to 25 or 30 or 35, that should be okay too. If you decide to extubate to have nasal high frequency ventilation, again, we use, hold on, I don't know why it's still running by itself. We use mineral pressure that is usually 2 centimeter water higher than the mineral pressure that the baby was requiring when intubated. The amplitude that we use is 1.5 to 2 times the mineral pressure, and we use a frequency of 8 hertz. So if the baby with mild lung disease and intact respiratory drive that was extubated to CPAP, it's well tolerated and is getting better, we start winning that PEEP pressure by following the daily oxygen histograms, clinical response, and if you have lung ultrasound in your unit, also by looking at the lung ultrasound score to be able to win that pressure. And every time you bring the pressure down, you follow the histogram, you follow the clinical response, and you usually repeat the lung ultrasound just to be sure that you haven't lost lung volume. If the baby does not tolerate the extubation to CPAP, despite optimization of caffeine and increasing the CPAP pressure, because the FiO2 goes up, or the baby start having significantly more apneas, or you do a gas and the CO2 has gone up significantly, then what we do is we switch that baby to either NIPPV or nasal high frequency ventilation, according to how familiar you are with one or the other. And when you are on this mode, and again, to be able to win from these modes, usually we win to nasal CPAP before we remove the device altogether. And again, we use oxygen daily histograms, we use clinical response, we use blood gases, and we use lung ultrasound to guide us how to wean these babies from non-invasive ventilation to regular CPAP. And I think that was the last of, no. So research question for NIV is synchronization essential? What are the most efficient ventilation settings for NIV? We still don't know that. What are the long-term pulmonary and neurodevelopmental effect of having these babies on non-invasive ventilation? Are nasal high-frequency ventilation now the future of non-invasive ventilation? We don't know. It needs to be more research done in these areas. And what's the effect of prolonged NIV support in oxygen saturation targeting and hypoxic events? So take-home message, only short-term benefit have been observed for NIV. There are uncertainties in the relative benefits of different type of non-invasive ventilation. As used in the recent NIPPV International RCT by Kirpalani, non-invasive ventilation does not increase survival without BPD in extremely birthweight infants, although, as I said before, this randomized trial was not real comparison between NIPPV and CPAP, but more BiPAP or bi-level CPAP and CPAP. And the success with NIV depends greatly on the skills and commitment of the caring personnel. Thank you. Sorry about the switching of the slides. I don't know why what kept going on its own. I can't hear you. I don't know if I'm the only one that can't hear you.
Can you hear me now?
Now I can hear you.
Okay. The review and your effort in preparing it is highly appreciated. Until now, we have two questions. The first question is, do you use an IPPV in delivery room? And if yes, what interface are you using? This is the first part of this first part. Are you using an IPPV? Second question, what interface are you using in the unit? I mean, I think they are asking the protocol of interface. Yeah.
Okay. For NIPPV, we got this new machine maybe a year ago. It's a machine that synchronized by flow. So we are still trying to get familiar with this device. So far, so good. The idea is to get familiar with this device in the unit before we take it to the recess room. But definitely, I think there is a role for NIPPV in the recess room as a primary mode of respiratory support, as the Cochrane database showed. So if you are familiar with the device you're using, yeah, there is nothing wrong with trying to use this device in the recess room as a primary mode of ventilation. Now, I would say that the easiest way to use an IPPV in the roomy room is the RAM cannula, because it will also allow you to transfer the baby on this device to the unit without significant problems. So that's what we will use if we start using an IPPV in the living room, the RAM cannula.
Yeah, now he's asking Dr. Ahmed or Dana Ahmed, she's asking which interface you are using in your unit. And maybe I will take the opportunity for this question to ask what protocol, how do you alternate between the interfaces to prevent nasal injuries?
Yeah, so we use the variable flow interface in the unit that allow us to use the fluidic change effect. That's what we use. Now, in terms of how we decide between SNIPPV and nasal high frequency ventilation, is really up to now is really staff dependent. Depends who is on service and depends how familiar you are with one or the other. That's the device that you're going to use first. And again, it also depends in which hospital you're working, because the nurses in one hospital are more familiar with one than the other. So that's what's going to determine which device we're going to use first.
Okay, thank you.
Again, nobody has compared, so far as I know, nobody has compared SNIPPV or NIPPV with nasal high frequency ventilation, as far as I know. So nobody can say that one is superior to the other. Study has shown that both are superior to CPAP, but there is no comparison between the two of them.
Okay, thank you. Now, another question is how you feed the baby. Do you feed the baby on CPAP?
Yeah, we do. I guess we're referring to feeding the baby orally, correct? Of course, we feed babies by tube on any kind of devices. We use the SYNC protocol that was developed in Calgary, Alberta, to progressively increase the volume of feeds while the babies are on CPAP. Okay, we call the SYNC protocol, and we start with very small volume of 1 ml, 2 ml, a few drops. That's SYNC A, that's the beginning, and then we advance as the baby tolerates that volume. 4 or 6 times. Then we move to the next level, which is B, and then C, D. I guess the last letter is, I think, is L, when the baby goes basically a semi-demand or early demand. But it's a very structured way to increase the volume when the babies are feeding by on nasal CPAP. Okay. Yes, we do.
There is a question. What's your experience in an IV for bigger preterm babies? They mean late preterm, 35, 36 week.
I would say that most of those babies, I wouldn't worry too much. And remember, the reason we are using NIV is to prevent intubation, because intubation is associated with BPD. What we are trying to prevent here is BPD. So, and of course, mortality. So we don't have BPD in babies over 32 weeks or even 31 weeks. So that's not the population that we are worried about. In that big population, I think using proper CPAP is more than enough. I don't think you will find a lot of studies showing that in late preterm infants, CPAP is worse.
There is problem in sound. We can't hear you. We lost we lost the voice. Yeah. Hello. Still, we can't hear you. Hello. Hello. Connection.
Okay. There you are. Okay.